Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. Today is our second lecture on eyelids, and in the previous lecture we discussed the anatomy of the eyelids, infections of the eyelids, inflammations of the eyelids, and benign lesions of the eyelids. Today, in the second and probably the last lecture on eyelids, what we will be discussing by the end of the lecture, our learning objectives are to know the definition and classification of ptosis, clinical examination of a case of ptosis, management options of ptosis, benign tumors of the eyelid, and malignant nodes of the eyelid. Okay? So without wasting the time, and before starting the lecture, if anyone of you has got any question, you can kindly stop me there and then. We will discuss it. We will try to make it out, and then we will move forward. I want this lecture to be an interactive lecture, so that the most which you can get and I can deliver from this lecture. And every day one learns how to learn, one learns how to teach. On the basis of my teaching experience, now I am making the videos. Previously I was not making the videos. To know my own mistakes first of all, and then for a reward from where you can then it is practically not possible to be trying to for a long time in the lecture, so the points some students might have missed, they can check it out on the YouTube where this lecture will be uploaded. I will share the link. And this is my new idea which came into my mind, because I used to make videos on small topics, so I thought that the lectures which I formally take in the class, they should also be recorded. So the camera is pointing towards the slide, and I don't know the clarity, it's just an experiment in the beginning. Yes. आगे आप इसको एडजस्ट कर दें
सब
मैं पूछ रहा था
सर थोड़ा सा इस तरफ आ जाए, इस तरफ आ जाए, थोड़ा सा इसमें नहीं आ रहा है, इसमें नहीं आप नहीं आ रहे, वो आ रहे हैं,
मैं आ रहा हूँ काफ़ी है
नहीं आप नहीं आ रहे
है नहीं यार मेरा आना कुछ भी नहीं है फिर इसको भी स्टॉप कर दो
स्टॉप करिए, पॉज
पॉज कर दो
स्टार्ट
ओके let's start and this is an experiment. I don't know what will be the quality. For the time being, we concentrate on the lecture. Today we have a lot of topics to be covered. So ptosis. What is ptosis? Ptosis. Silence please. As this lecture is being recorded, so silence is very important. What is ptosis? Anyone? It is the drooping of the eyelids, usually upper lid. Rarely it can occur in the lower lid also, but we will confine ourselves to the undergraduate level. It is defined as drooping of upper eyelid to a level that covers more than 2 mm of the superior cornea. This definition gives us a clue, this an information that till 2 millimeter, if the eyelid covers the cornea, it is normal. If it is more than 2 millimeter, then it is called drooping of the eyelid, which in medical language we call ptosis. Patient will come to you and he will say कि मेरी आंख ऊपर जो eyelid है या छप्पड़ बोलते हैं उसको पंजाबी में बोलते हैं वो गिर गए. He will come to you by saying this. And normal elevation is largely a function of levator perpetuus superioris, which is the sinus. This upper eyelid is supplied by two muscles, levator perpetuus superioris, which elevates the upper eyelid, and ocularis oculus, which closes the eyelid. So, if upper levator is affected by muscular dysfunction or problem with the innervation, which is supplied by the third nerve, oculomotor nerve, then ptosis can occur. You will see in the coming slides what are the possible causes of the ptosis. So you can see in this picture there is the drooping of the right upper eyelid. So it is right ptosis and mild ptosis. You will see the gradients of the ptosis also. These are this is the classification of the ptosis. Number one, congenital. Number two, acquired. Science. Congenital ptosis can be simple or dysmyogenic, as the name suggests and tells you a lot. There is maldevelopment of the levator muscle. Okay, and acquired has got four causes. One is aponeurotic, one is myogenic, and the last one is mechanical. We'll see the details. Aponeurotic ptosis. You can see in the right eye, the upper eyelid is drooped, and as compared to the left eye, the upper eyelid crease. This is the upper eyelid crease. Can you people appreciate it? Huh? Yes. And you cannot appreciate it here because it is absent. And this upper eyelid crease is made by almost 10% of the fibers of levator muscle, which pierce or insert in the skin of the upper eyelid. 90% of the fibers are inserted on the tarsal plate, upper part and anterior part of the tarsal plate. But these 10% of the fibers are responsible for making of the crease. With the passage of time and aging, this is the aponeurosis, the peptide structure, and these become descends and loose and damaged, and then they are pulled away, and sometimes they are torn out, and the result is a mild ptosis, and the cause is this damage of the aponeurosis of the levator. Got it? And the main sign is that you will not be able to appreciate the upper eyelid crease because the fibers are gone. So the crease is also gone because it is seen because of the inserted fibers. Causes are very obvious: involutional, that is aging, and post-operative. In some cases, like cataract surgery, we use a bridal suture, that is false suture which we apply to the superior rectus muscle to stabilize the eye and to move it at our convenience. Silence is in that maneuver, sometimes we damage the levator muscle. Iatrogenital. That will also cause this type of ptosis. And this will come under the heading of force operative. आवाज कहाँ से आ रही है? बोले नहीं please. Now neurogenic ptosis. Third nerve is supplied by which nerve? Not facial. Oculomotor. This is a very common between third nerve and seventh nerve. जब when someone suffers from Bell's palsy, जिसे लकवा बोलते हैं, तो उसको उसकी सेवंथ नर्व पाल्सी होती है, उसमें पेशेंट की आंख बंद नहीं होती, and seventh nerve is a motor या motor nerve, and it supplies the orbicularis muscle. Am I right?
Yes.
It supplies the orbicularis muscle. Therefore, orbicularis muscle becomes unable to close. As a result of it, its agonistic muscle, which is levator muscle, elevates the eye, and the patient is unable to close the eye. And the opposite to Bell's palsy is a ptosis, in which the third nerve is damaged and the levator muscle is gone. Now not the orbicularis muscle will pull down the eyelid, but the levator muscle is no more there to keep the eyelid at the proper place. So as it is no innervation, it will go down and the lid will droop and ptosis will occur. And we call it neurogenic ptosis. And usually it is total ptosis, as you can see. And in third nerve palsy, we usually see this type of picture, oculomotor nerve palsy. Causes of neurogenic ptosis are third nerve palsy, Horner syndrome, Marcus-Gunn jaw syndrome. Third nerve palsy is द्वारा लिखा गया. So these Horner syndrome you people know already. And Marcus-Gunn jaw we will discuss when you will come in the bones. Myogenic ptosis, as you can see, both the eyes are ptotic and it is congenital, and congenitally the levator temporal superioris muscle is not developed embryologically in a correct manner because of some embryological developmental anomaly, and the nerve is okay, but the muscle is this means dysfunctional. So it is dysmyogenic ptosis. Causes of myogenic ptosis, that is related to muscle, are of acquired ptosis. That was congenital. This is acquired. Most common is myasthenia gravis, not unknown to you, a very common disease. Myotonic dystrophy, ocular myopathy, simple congenital ptosis, and blepharophimosis syndrome. Now, I feel all of you know the myasthenia gravis. There is myotonic dystrophy is a special type of muscular dystrophy in which there is problem in the muscles of the face and the hands, and retina of the eye is involved. It is not very common. Similarly, simple congenital ptosis, as we saw in the previous slide, is relatively common, and blepharophimosis syndrome is a special type of syndrome in which ectropion and other eyelid problems are also present. It is a special category, and if we get the time, then we will study this also. Third is the mechanical cause. Anything which is pushing the upper eyelid downwards will cause ptosis logically. For example, it can be a big lesion on the upper eyelid, as meibomian glands are present more in the upper eyelid. Why more in the upper eyelid? Because the upper eyelid is larger than the lower eyelid. So the chances of lesion are more in the upper eyelid. Because lesion is the granular metal inflammation of the of the meibomian gland. So a very large lesion may cause ptosis. Some other ocular mass, for example, some tumor like basal cell carcinoma, sebaceous gland carcinoma, if they are present on the upper eyelid, they can cause ptosis. If there is dermoid cyst on the upper eyelid, it can cause ptosis. Any sort of mechanical pressure, it can cause ptosis. Lesion, eyelid tumors, eyelid swellings. Swellings can be because of less reaction of the eyelids, and in some systemic diseases like nephrotic syndrome and things like that, where the swelling of whole of the body occurs, if it involves the eyelid, the result will be ptosis of the eye. Are you getting my points? Now, in this slide, you see the compensatory mechanisms which a ptotic patient will adopt. Depends upon the laterality of the patient, complete or partial, frontalis overaction, frowning, altered head posture. So, if the ptosis is bilateral, the patient will have a chin up position like this, as you can see, because when he will move his head up, only then he will be able to see from the eyes, because in the normal position the lid will cover the cornea, and abnormal head posture means when he elevates the chin, it is no more a normal posture. So these are the things. If it's partial, he may not elevate the chin, and he can use the other. And if the patient is a child, this is a very important point. If the patient is a child, especially under the age of 11 years, and he has unilateral ptosis, and parents or doctors do not take it seriously, what it will do, patient will only use the normal eye, and the other eye, which is ptotic eye, will not be used, and it will develop amblyopia. And there are many types of amblyopia. It will develop sensory deprivation amblyopia, because the image is not being projected on that retina of that eye. So it will develop the sensory deprivation amblyopia. Same can amblyopia can be developed in congenital cataracts. Yes? Yes, please. Okay? Sensory deprivation means that the sensation of seeing is not being received. So you have to take care of, or you have to operate upon it before the age of 11, because binocular single vision and stereopsis develops before that age. After that, there are many problems, and vision may permanently be decreased. Besides that, the eye is anatomically it's okay. Ptosis examination. Now, this is a very important slide. If you remember this slide, then your whole ptosis examination will be covered. In this lecture, we will discuss the theory of the Ptosis examination. When you people will come in the eye ward, we will discuss and we will perform these theoretical tests practically. How they are here uh, we will discuss, learn how they are performed, and in clinics we will perform them. So try to understand. Number one, palpebral fissure height. Palpebral fissure height is the simply is measured by a transparent ruler, and it is the distance between the upper eyelid margin and lower eyelid margin from the center. It is not a very the upper eye distance between the upper eyelid margin and lower eyelid margin. It is called palpebral fissure height or vertical fissure height, and it is very simple to measure. Not a very big thing. In Ptosis it will be decreased. Okay. Normally it is 10 to 12 millimeter. 10 to 12 millimeter. What is MRD? MRD is marginal reflex distance. This is palpebral fissure height. The distance between the upper and the lower eyelid. Okay? MRD is that when you show the light into the cornea of the patient, eye of the patient, you will see a reflex of the torch light on the cornea, right? And the distance between the upper eyelid margin and that corneal reflex is called marginal reflex distance. It is normally 4.5 millimeter in all in the general population. You can see this is MRD. The distance between the upper eyelid margin and this corneal reflex, this whitish reflex which you can see on the cornea, is the reflex of the torch. It is 4.5 millimeter normally. Is it clear? Okay. Lid crease position. Measurement of the upper eyelid crease. Here we ask the patient to, in the left side you can see, on the right side you can see the upper eyelid crease, which we discussed in the apneumotic process. These are this crease is formed by fibers of the levator aponeurosis. Then we ask the patient to see downward, upward and downward, and here a very mild, very light crease can be appreciated. You will measure it from here. This is the crease, from the crease to the upper eyelid margin. Okay? And it is also almost 10 to 12 millimeter, 10 to 12 millimeter in its length. दोनों में करनी है। ये सारे टेस्ट जो आपको बता रहा हूँ ये आपने बाईलेटरल करना है, ठीक है ना? When जब आप बाईलेटरल करेंगे, only then you will be able to see, will be able to appreciate the defect in the other eye. Okay? Then after lid crease position is the levator function. Levator function is the very important point. It will be very difficult for me apparently to explain it to you people without performing it. And if I try to explain uh, then I will be short of time. Therefore, I will be skipping this point and we will discuss it later or in the clinics. But this is the most one of the most important points, and it tells us about how much power is present in the levator muscle. Marcus gun jaw winking is a phenomenon which is congenitally present. As you can see in the right picture, the child is okay. And in the left picture, when she is eating something, her upper eyelid is ptotic. So when the child chews or eats something, the upper eyelid keeps winking, like sometimes opening, then closing, opening, closing. It winks and it looks very bad. And it's a congenital problem, and the patient carries this disease to the adulthood. And for its treatment, we have to perform broad suspension, that is, we have to disinsert the levator muscle from its from the its origin, and we the surgery we perform is broad suspension. That is, the tarsal plate is tied to the frontalis muscle. Okay. Ptosis classification. If it is mild, then it is less than 2 millimeter. Moderate is 3 millimeter. Severe is 4 millimeter or more. And levator function test, which we the slide which I skipped. By that we measure how much millimeter is the function of the levator. If it is 8 millimeter or more, it is good. If it is 5 to 7, it is fair. And if it is 4 millimeter or less, it is poor millimeter. And this is very important because on the basis of the levator function strength, we manage our surgical intervention. And nowadays, the most commonly performed surgery to crack the ptosis is levator muscle resection. We shorten the levator muscle. And for example, this is the upper eyelid and this is the ptosis. Okay? And if I cut from this point to this point, what will happen? It will shorten the muscle and it will elevate the eyelid. How much we will resect? How much we will resect is decided. How much? अभी तक वो माइक हो रहा है थोड़ा. Hello? How much we reset the levator function, levator muscle? It depends on the severity of the ptosis. And there is a table and special formula which tells us that how much millimeter of resection of ptosis will recover how much of ptosis. For example, if we resect 5 millimeter of levator muscle, it will tell us that table after many experimentation that it will resect 5 or 6 millimeter of levator muscle, then it will recover so and so much millimeter of ptosis. Got the point? Is it clear or not? नहीं? यानी अगर आप लेवेटर मसल को 4 मिलीमीटर हिस्सा काट देते हैं तो कितने मिलीमीटर प्रोसेस ठीक होगा? Okay, these are surgical treatment options. Uh, Casanera servant, the uppermost is for mild Ptosis like Horner syndrome. We will discuss the surgical procedure, science please, and levator section. Levator section. It can be from the anterior or the posterior approach, that is from the skin side or from the conjunctival side. Usually we perform it from the skin side, and we dissect the skin, then the subcutaneous tissue, and then we visualize the levator muscle. With a special gauge, we measure the levator muscle and decide how much to cut. So, and frontalis suspension is vast, and the frontalis suspension, when the levator function is very poor, then we are left with no other option than to with the of ideally to take the facial area from the thigh, because it is the least damaging in the sense that the body does not respond against it, and we, or if it is not available, then we use porcelain suture, suture which is made up of porcelain. We tie uh, tarsal tapes to the frontalis muscle. So when the patient falls, he uses his frontalis muscle, and as a result, as it has been tied to the tarsal tapes, what will happen when he will fall? The eyelids will be elevated, and he will be able to see. And when he will stop frowning, the eyelids will come to relatively a normal position. Not total position, relatively normal position. Maybe a little more, little losses, but it functions very well in the cases where we don't have any other option. How much time we have left? Okay? Okay, benign eyelid tears है. Listen to me. Listen to me. I will request. किसके रखते अगला? I will request community to give us a couple of minutes. Okay, we have 5 to 10 minutes. We have requested Dr. Rashi, and he has kindly allotted us, given us extra time. I just want to read this lecture. Benign, silence please, silence. Benign eyelid lesions. मैं इनमें जो इम्पोर्टेंट चीजें हैं उन पे ज़्यादा स्टे करूँगा. Viral warts, squamous cell papilloma, as you can see. Your आवाज बनाए please. I am telling you again and again, and I can see clearly the road which is creating a problem, and you people are sitting in a very congested manner. You can sit very easily. There is a lot of seats there. So, please try to cooperate with me. It is the most common benign tumor of eyelids, size pedunculated, as you people know, pedunculated or broad-based lesion. That this treatment is surgical excision, cutaneous form. It is a condition which may be associated with squamous cell carcinoma. It is a hyperkeratotic lesion. Treatment is surgical incision. It just looks like this on the upper eyelid usually and develops slowly. Patient ignores it, and if he continues to ignore it, usually in the rural areas, then he may come up with this disastrous uh, looking picture, but it's benign. Most of you people must be knowing about gel. So I am skipping it. It is the deposition of cholesterol and has no significance other than cosmetic uh, problem. And in those cases, we just remove it is deposition in the subcutaneous tissue. We remove it and we send the patient for some investigation to see some liquid abnormalities. This is hemangioma. Usually there are two types: capillary hemangioma, and the other is, madam, just 5 minutes, please. No, just 5 minutes. Okay. Capillary hemangioma and cavernous hemangioma. Former are bright and red spotted, all or port wine colored spots composed of dilated capillaries. The latter consists of dilated anastomosing muscular spaces lying in the subcutaneous space. ये later है, ये first है. इसको आप skip करें. Malignant tumor जो सा है, ये 3 आपके रह गए हैं, ठीक है? And I think I will not be able to make up, and I will have to stop here. So, in this second lecture, we have malignant tumors left with us, which we will cover in our second lecture, along with probably diagnosis. Any questions, please? No question? Okay. Attendance, please. Thank you very much.